Good evening, and thank you very much indeed for joining us. And of course, for watching Inside Government. We are live from national headquarters. This is Kenya Broadcasting Corporation. Tonight, we just want to delve into some very, very scary statistics. And I want to take you through cancer management in the country. I mean, when you look at the disease, the third largest killer disease in Kenya. And within a span of 5 years, more than 102,000 people will be living with the disease. And out of these, 27,000 will die every year. That's right. So let me put it into perspective. Between the year 2022, when we went to the general elections, and the year 2027, 102 people will be living with cancer in between. Out of these, 27,000 people will die every year. That's right. So these are scary statistics, but we have to live with them. And the question is, what are we doing as a country to manage this crisis? I mean, we have come up with a plethora of issues, of policies, and of course, organizations. And tonight we just want to discuss cancer management in Kenya. And we are talking to the National Cancer Institute of Kenya. It's an organization that was formed back in the year 2012 to help in the management of cancer, management and control of cancer in Kenya. We'll be looking back at the last 13 years and we'll be asking ourselves, what have we achieved in the last 13 years? What are the milestones? What are the hits and misses? And what is the way forward? So joining me tonight on Inside Government, we're talking to Dr. Michelle Nguu. She is the Director, Cancer Prevention and Control Directorate at the National Cancer Institute of Kenya. Thank you very much indeed, Michelle, for joining us tonight.
Thank you.
And next to Michelle, we have Phoebe Ongadi. She's the Executive Director at Kenya Network of Cancer Organizations, joining us tonight as well. Thank you very much indeed, Phoebe.
Thank you very much.
Very good. I just want to start with Dr. Michelle. Give us a statistical breakdown of what is the status of cancer in Kenya today?
Yeah. Thank you, Brian, for that question. And I think you've highlighted it in your opening remarks. Cancer is the third leading cause of death in the country after cardiovascular diseases and infectious diseases. Mm-hmm. So what does that mean? It means the latest Global Can report of 2022 estimates that every year 47,000 people will be diagnosed with cancer. 47,000? 47,000. Mm-hmm. And actually, we do acknowledge that there could be cases of underreporting, so the numbers could be much higher. Mm-hmm. Out of that 47,000 people, in a 5-year period, we'll have over 102,000 Kenyans living with cancer at various stages. Mm-hmm. And then annually, we report 27,000 deaths. And actually, reports from WHO says that that number could be approximately higher to up to 33,000. Mm-hmm. So what does that mean? Unfortunately for us as a country, other than the numbers being high, we also have issues of late diagnosis. 70% of those 47,000 cases I have mentioned, they will present to the facilities at late stage. So I mean stage 3 mm-hmm. to 4. Mm-hmm. So what does that mean in terms of management and the care given? It means that for late diagnosis, the goals of care have to change. So they change from curative mm-hmm. to palliative. Mm-hmm. Yes. And by the time you get to palliative, it means that the disease or the cannot be reversed. It cannot be reversed. Yes. So the only thing that would happen to you is that you're going to die. Going to die, but we also want to look at palliation in a very different aspect. Mm-hmm. We want to look at palliation as actually from relieving of pain to symptom management. Mm-hmm. You can find some cancers, maybe, for example, if it's a growth, it's causing pain, discomfort. We can actually do surgery for the purposes of alleviating mm-hmm. The symptoms and also to manage pain. But in those late stages, it means that the cancer has more than likely metastasized to other regions. And of course, with late stage also means it's more expensive, and Phoebe, I think you agree with me on this one. It's more expensive for us to actually manage that cancer at that time. Mm-hmm. Yes.
Help us understand this. Is it possible for somebody to come from palliative? Is it possible?
Oh, Brian, no.
It's not possible.
No, yeah. Once
so the moment you get into palliative,
yes,
then
yes,
that's the end of it.
Yes, yes.
Wow. Phoebe, help us understand things. I mean, you know, Kenya has been dealing and, of course, battling, you know, with a high burden of cancer, you know, in the last 20, 25 years. Are you convinced that the policies that the government is putting in place is helping to alleviate the suffering of cancer patients in Kenya?
Thank you so much, O'Brien, for that question. And we would look at the policies in two tiers. So one of the policies that is guided right now by the National Cancer Institute, looking at the National Cancer Control Strategy that is currently on ground. Mm-hmm. So the government really tries to come up with solutions, especially on what Dr. Michelle mentioned on late diagnosis. That is why Kenyans are dying. That is why we are having those statistics, because we are diagnosing cancer very late. And what the government has tried, one of the things to appreciate is on formulation of the universal health coverage. Mm-hmm. So universal health coverage was now under the SHA authority. It was supposed to help with early diagnosis. It was supposed to help with early screening and all that. So they're really trying to try and find out or avenues and ways of having cancer diagnosed early. They're really trying to look at the prevention, look at the efforts right now, for example, for the cervical cancer. We have the human papilloma virus vaccine that is currently rolled out. So for the civil society, we look at why is it that the government has rolled it out and yet the uptake is still low. So we come in by bridging that gap by doing awareness and sensitization. Because you can imagine somebody coming to save the girls from getting cervical cancer in future, which is the #1 leading cause of death among the cancers in women. So that is one way that
cervical cancer.
Cervical cancer, it is the #1.
It's not breast, prostate?
No, breast is in terms of incidence. So the numbers are breast, but the mortality is cervix. And this is one of the cancers that can be prevented. So of course, government has tried to roll out that one, and there's still low uptake. And as of this year, was it May? They now, because they used to do a double dose. So a girl will go between 10 to 14 years, will go at maybe 1, and then they go back after 6 months. Right now, they're doing a single dose. So those are some of the efforts that the government is doing. And another one that we have to mention on universal health coverage, it's really beautiful on paper and it is well done. But now we are trying to see, we are looking at it 1 year later, and we're currently looking at especially the universal health coverage 1 year later. Where are we? What can we improve? How has it been? Are the patients getting help? Is it helping to improve, especially on the late diagnosis? Is there survivorship support? Is there palliative support? Is there rehabilitative support? So those are some of the ways. And of course now, what is also working is with the counties, because health currently is devolved. Each and every county, the comprehensive cancer centers, the government is trying to put comprehensive cancer centers in all the counties. But again, we are coming to say that it should not just be a center, it should be a fully placed center with oncologists, with the equipment, with the laboratories, with everything that the patient needs, so that a patient from Narok does not have to come all the way to Nairobi to access cancer services at Kenyatta National Hospital, and yet they could access it near their homes or near their regions. So those are some of the initiatives that we feel that the government is trying. Though we are not yet there, it is still #3 leading cause of death, but we feel it is trying to improve the situation. Yeah.
You talk about the government trying, and of course, we know that you know, cancer prevention, management, and of course treatment, you know, is a long-term strategy.
Yeah.
But when you look at, for example, the national cancer policy that was launched in 2020,
2023.
2023. Do you believe it addresses the challenges that we are currently facing because of cancer, and that we are going to face by the year we get to 2027 because of cancer?
The policy document, as it is, addresses the challenges. The challenge comes with implementation. Implementation, because if you look at the policy document, it covers all the continuum of care, right from diagnosis to treatment to palliative to survivorship support. It covers the whole continuum. But then we are going back to the policy and asking, is it really implementable on the ground? And that is now where advocacy comes in, to bridge implementation and policy. What is in between there is advocacy. So we are constantly looking at that document, constantly reviewing it, constantly questioning it, it and constantly having our voices heard so that they do the improvement. I will give you an example. For example, I'll just go back to the universal health coverage again. There is the primary health care as a policy. The primary health care was supposed to come in and bridge the gap on diagnosis, because the reason why Kenyans are dying is because of the late diagnosis. But now when we come back to primary health care, we are telling Parliament, okay, please put the capitation in the primary health care so that it does the work that it was supposed to do. It was actually supposed to capture the diagnosis so that if you go to hospital, for example, with difficulty in urine, and you're a man above 50 years of age, you should be sorted out with the right diagnosis to get to the root of it. So as a document, it is working, but we are constantly looking at it and seeing the areas that is not working and constantly putting the government to account.
And of course, you know, when you look at the mandate of NCI Kenya, I mean, what part of it is prevention.
Yes.
And of course, prevention, you know, involves, you know, alerting members of the public or embarking on civil education. That for you to avoid getting cancer, these are the steps that you need to do. This is a kind of lifestyle that you need to live. Are you doing that?
O'Brien, let me actually pick up from where Phoebe started off. Does the government have a plan to tackle this public health concern that's cancer? Yes, we do have a plan. And the plan is well highlighted through the National Cancer Control Strategy 2023-2027. So for me to answer that question, allow me to highlight how we've implemented that policy document up to now, so that even if the issues are sometimes about implementation, we have to give credit to the government where they have actually done considerable amount of work. So the National Cancer Control Strategy has 5 pillars. The first pillar goes back to the question that you just asked me. Have we done enough in terms of prevention and early detection? Yes, we have. Right now, as we speak, we are able to screen over 50,000 people annually.
50,000?
Yes, and that is breast, cervical cancer and prostate cancer. We do that as a government entity, as National Cancer Institute, and also when we work with partners. Again, for what she said about HPV vaccination for girls aged 10 to 14. As of 2023, we had screened around 1.9. The target was 2.3. We had screened, 1.7. That's around 53% of the targeted population. Now, with the introduction of the single dose by the government, which is an adoption of the WHO strategy, that means we'll be able to vaccinate more girls because it addresses the concerns that we had, which were financial constraints, limited workforce, and that. Number 2, we go to the second pillar. This pillar basically deals with diagnosis, that is imaging, laboratory medicine, and pathology. Right now, she mentioned that the cancer care continuum in the country, we've structured it in such a way that it works in a hub and spoke. So we have 6 regional diagnostic centers in Kenya that are able to offer pathology services to the patients. Again, to loop in the social health insurance.
And where are they, the 6?
We have Nairobi, okay, K2RH, we consider that Kiambu. We have Moi. We have Garissa.
That is in Eldoret.
Yes.
That's in Gishu County.
Yes. We have Nakuru, we have Garissa, we have Mombasa. You can see 6. And also the government is constantly working to improve the scope of services in these facilities. So even when you talk about diagnostic, remember, for the first time, SHA, which is, we've graduated from NHIF, under SHA, we cover diagnostics for cancer.
Up to how much?
Up to 100,000.
100,000.
Yes, that means for a lady.
And how much do you need on average? As a
roughly, based on our calculation, that 100 is enough for us to initiate the first care.
The first care.
The first care. Up to us finding something wrong, laboratory, biopsy, immunohistochemistry, starting treatment.
In the 5 facilities? In the 6 facilities?
In the 6 facilities. Some county facilities are actually doing impeccable works in their counties. They just don't get the avenue to speak about
like which county?
For example, Kitui.
Kitui County.
Kitui County, Makueni County.
What are they doing differently?
Kitui County has a very small but very precise diagnostic capacity. So they're able to do your biopsies, your pathology there and initiate treatment. Same for Makueni. And I think we have to give it to those counties because they've seen the need for their community and they've actually put in the work, put in the finances. So as I was continuing...
So 100,000 is for diagnosis?
Diagnosis, yes. So for example, you see what would happen with an HIF, a lady would get a breast mass, right? Do the biopsy. you see, it wasn't enough for us to know what type of cancer this is, because there are different types of cancers. So what we call the immunohistochemistry, they would have to dig out of pocket to pay for it. At that time, it was costing around anywhere between 15,000 to 20,000. Brian, not many Kenyans can afford that out of pocket. But right now, with SHA, that is covered. So means from the time we tell this lady that we are suspecting you to have breast cancer, up to the time that we think we are going to start you on this chemo plus this targeted therapy, everything has been covered by SHA.
By SHA?
Yes.
That is on diagnosis?
On diagnosis.
Still, before we get out of that point, the 100,000 shillings, if you were to go to private hospital, is that enough?
Now, you see, for SHA, we are government, so we work within government facilities, but we do have private facilities that have signed
But are
MOUs.
the six government facilities, do they have the capacity to handle the number of cancer diagnoses and management in Kenya?
Of course, they do not have the entire capacity, because also when you talk about capacity, we also talk about the availability of the adequate human resource for health. That is an entire continuum of care, not just in cancer, but the entire spectrum of healthcare. We do not have enough health personnel. Again, something that the National Cancer Institute is addressing through our training programs. Yes.
Very well. Yes, move now to the next stage,
so,
after diagnosis.
We go to treatment. Treatment for cancer ranges from surgery, chemotherapy, radiotherapy, a combination, targeted therapy, immunotherapies. And I think also as a country and as the government, we're actually doing pretty well in that regard. Because if you really follow what the Ministry of Health does, in the last couple of months or 4 weeks ago, we have signed 2 significant memorandum of understanding. One with Roche to provide a drug called Herceptin. It's a targeted therapy for breast cancer. Again, I think Phoebe mentioned that breast cancer is the #1 cancer in the country for us. So this that MOU, what it has led to treatment cost implication, it has reduced the cost of treatment to up to 66%. A treatment per cycle that would cost around anywhere between 120,000 to 140,000 now is around 30,000. Again, that's the MOU that has been brought again by the same government, targeting to reduce the cost of treatment in cancer. Recently, we also signed another MOU with Pfizer, a code for a healthier world. We have 49 molecules for oncology. These molecules are coming to us at no cost. And also when we work with government, when we procure in bulk, we save. When we procure at bulk, we save. And all these protocols, again, the Ministry of Health is working tirelessly with all the stakeholders that are involved in treatment, surgeons, gynecologists, oncologists, clinical oncologists, to come up with protocols that are going to standardize care and also standardize payment so that we do not have people, overcharging for cares when we have protocols.
Help us understand things, under the Social Health Authority. How much will SHA pay for treatment, let's say, in 12 months?
O'Brien, I really do not think I can answer you that question right now because it would have to be really backed up by the latest data. But we are doing things to improve
on average?
That. On average, per patient, around 1.2 million, and that's just a very rough figure. 1.2
million shillings?
Yes.
That is what a patient would need.
That's what a patient would need to.
And how much will that be covered by SHA?
The reason I've given that estimate is because with NHIF, we used to have a coverage of 600 per person. And if you have a spouse, once you run out of you exhaust your 600,000, you would actually use your spouse's card to continue with your treatment. Again, for the SHA...
Is it happening now?
Remember, the oncology benefits package under the SHA is a flagship scheme. So there's a lot of learning, there's a lot of reviewing. Yes.
Let me hear from you. She has brought in the numbers, and I mean, globally, cancer management is treatment and management is very expensive. Because even the cost of hiring oncologists, experts in this field, it's also very expensive.
Yes.
No wonder you don't have many oncologists in Kenya. You don't have diagnostic systems in many hospitals in Kenya. So are you convinced that SHA, when you look at the amount of money it is covering per patient for treatment of cancer every year, is it enough?
Thank you, O'Brien. I think, let me just start by giving credit where it's due. SHA is working, and SHA is not working in both ways. So how is it working?
So which statement
it is
do we
working.
believe?
It is working because from July, remember July when there was transition between NHIF and SHIF, they did a very small package for the hematology and also oncology package. But when we look at it between July and now, the government came up and said that they have done a 400,000 basic, that is under the social health insurance funds. Remember the universal health coverage, the SHA is 3-tier. There's the public health, primary health care. The primary health care is supposed to cover the diagnostics and all that. And that is what Doc is saying is at around 100,000.
That's primary.
And then there's, primary health care. On paper,
So what is primary?
Primary is basic treatment.
Basic treatment from your screening and everything. And the beauty about it, O'Brien, we have 25 million, approximately 25 million Kenyans registered for SHA right now at the moment. Then we have around 4.5 to 5 million who are actually registered and paid up. But guess what? For the 25 million, they can access the services under the primary health care fund and the emergency and chronic and critical illness fund.
Very good.
So let me just proceed. So the primary health care fund that Dr. Michelle is talking about is true on paper. It should be there, but not all patients are accessing. You know, I told you when we started that we are looking at SHA 1 year later. And when we are doing analysis of our program, we start with the positives. The positives is that the cap of the social health insurance fund of 400,000 Kenya shillings per patient is working. They're able to access 400,000 Kenya shillings. The challenge comes when the 400,000 Kenya shillings is depleted. And that's why, if you look at the media, there were no complaints between August, September, October, actually up to around April, because most of the patients were able to access the 400,000 cap. Now, the challenge came now when that cap is exhausted, when they're supposed to access the emergency chronic critical illness fund, which was increased. Again, we give government due there. They increased it to 150,000 Kenya shillings. Remember, the source of the social health insurance fund should be the contributions. By members. The source of the emergency fund is from exchequer, from grants, donations, also from Act Parliament and all that. So our only issue right now is that not all patients are able to access the 150. We are okay with 400,000. We are okay with accessing that much, but we are not okay with accessing the 150,000 Kenya shillings. And of course, in our analysis, we are giving out feedback, because at the end of the day, the National Cancer Institute, the civil society, the government, we are all working towards the betterment of the patient. And for us, we want the universal health coverage to work so that the document that is on paper is transferable. So the only one of the challenges that we have met, there are only 3. And if those 3 can be addressed, I think we will be okay. So the first one, they're saying National Health Insurance Fund was giving what we call the individual cover. So that means, O'Brien, if you are your wife, and you had the NHIF, if yours get depleted, your wife will still come and use your cover as a dependent. The difference with social health insurance fund, which is fantastic again, that the patients can access the 400,000, but once it is household-based. So it means if a household depletes the 400,000 Kenya shillings, it is all of you. So even more unto you, if there are 2 individuals in that house that have a chronic illness, it means it will be depleted faster. So we are requesting that in the analysis, it has worked in the year, but now can we go back to the drawing table and say, we either go back to the individual coverage or we stretch it just a bit, because the law allows us, the policy allows. If you look at the Social Health Authority Act, it actually allows for the government to put in, because now SHA is saying they have a challenge of having the informal sector. Not everybody has dipped in. We understand, because if there is no money, how will the people be covered? We are also now appealing to everyone, all Kenyans, please get the social health insurance fund, because when you do so, you will have saved a patient, a family that is grappling cancer, not only cancer, but also chronic disease. Number 2, what they are telling us right now that is coming out very clearly is that they are not able to afford the yearly or the annual payments. It is a fantastic idea, because it will make sure that we always have, because what SHIF does, it puts all the money in a basket. So we will the more people pay per year, we will have a lot of money, and that's the universal health coverage idea that this government came up with, which worked. But now, we are having a challenge because it is not enough. So if it is not enough, not everyone, especially from the informal settlements, can pay the 1 year. Yeah. So we are requesting, as we review, can you go back to the policy and even do a half year? For example, 6 months. It will be better for that mama mboga to access it rather than asking them to pay 7,800. Or can you do it even 3 monthly so that we have a better package for it? So that's why you see when I started, I said it is working. 400,000 Kenya shillings is working, but we cannot access the 150 chronic illness. On paper it is there. I can see it on UHC, but now we are not able to access it. So if those are added up from the exchequer, it will be fantastic. It is going to be it's going to be fantastic. Of cancer
patients in Kenya.
Yeah.
Very good. I mean, if you're just joining us, we are coming to you live from Broadcasting House. And of course, our conversation tonight is on cancer prevention and management here in Kenya. We're in the company of Dr. Michelle Ngu. She's the director, Cancer Prevention and Control Directorate at the National Cancer Institute. You're watching us live from Broadcasting House, and of course we're in the company of Phoebe Ongandi. She's the Executive Director at Kenya Network of Cancer Organizations. We are taking a short break, and thereafter we are back with more conversations. Stay right here.
Wait.
Premium flour, nurturing the world. Available in a store near you.
Aya, yani tumeuza pikapu mzima saa hii.
Imeisha. Ai, kila mtu anataka kununua kwako.
Siri ni hii, mimi hupanda na dhabiti DAP, na palilia na dhabiti CAA au dhabiti urea. Na bas, matokeo ni mazao ya ajabu.
Thabiti Algon Fertilizer is your surest partner in successful farming. Thabiti is available in various sizes that suit your pocket. Algon Kenya, transforming farms and lives through technology.
Anaichanja ndani uzuri David!
Michuano ya CAF ya mataifa ya Afrika 2024 ni njia ya kuzindua kupanua mtandao wa wachezaji ulimwenguni. Timu itakayoshinda itazawadiwa dola za Marekani milioni 3.5 pamoja na kujivunia kulinyanyua kombe hilo. Pata manufaa zaidi kutoka kwa CHAN 2024 mubashara na kipute cha kipekee kwenye runinga ya KBC Channel 1, mwenzio wa dhati michezoni.
At the heart of Kenya's transport infrastructure is the Mechanical and Transport Directorate, MTD, under the Ministry of Roads and Transport. We oversee a network of services spread across 24 strategic regions, ensuring efficiency in plant and transport services nationwide, from road construction and maintenance to the provision of specialized equipment to manufacturing services. We support infrastructural development across the country. We carry out inspection and valuation of government vehicles, plant and equipment in view of pre-delivery, repair and maintenance and disposal. We also inspect second-hand imported motor vehicles for roadworthiness as per KEBS KS 1515 and conduct occupational tests for drivers and operators. For more information, visit mtd.go.ke or call 0718 976 445. The Mechanical and Transport Directorate, Quality Mechanical and Plant Services. There there is something that drives us to become the people we are, the people we care most about. Thanks to Madison Better Life Medical Cover, your family can now have access to the best care 24/7. Go ahead, take on the world with Madison Better Life Medical Cover today. Call us today on 0709 922 666. Madison Group, life without worry.
Meet the experts who empower you with competent skills at craft, certificate, and diploma level. Sensei Institute of Technology. My skills, my future.
First match of this Chan here, but Yambo goes directly a goal and Columba's across quickly. Great footwork from the goalkeeper. Very consistent goalkeeper. Won a couple of league titles and the APSA Cup for Red Arrows in recent years. Yambo hits it nicely, but Columba. Excellent footwork.
Premium flour, nurturing the world. Available in a store near you.
You know, cancer management is taking a toll on the Kenyan economy and, of course, on Kenyans. I mean, I gave you some very scary statistics about the number of cancer patients in a span of 5 years and the mortality rate in this country. And that's why the government has come up with a number of initiatives to try and alleviate the suffering of cancer patients in Kenya and, of course, deal with the burden of cancer management among patients. Tonight on Inside Government, we are in the company of the National Cancer Institute of Kenya, Director for Cancer Prevention and Control Directorate. This is Dr. Michelle Go and Phoebe Ongadi, who is the Executive Director at Kenya Network of Cancer Organizations. The first hour is down, and of course, time now to get into the next 30 minutes before we call it a night. You know, before we went for the break, I wanted to find out from you, Daktari, cancer is a highly specialized, cancer treatment is a highly specialized area. And you are giving me some statistics that we have about 58 oncologists in Kenya.
Yes.
Are they enough to treat the 102,000 patients in Kenya?
O'Brien, I was actually looking at a report I had prepared for the ministry just the other day, and of course they are not enough because we found that we have around 58 oncologists, and actually 30 of them are registered as radiation oncologists because there is a difference. And when we look at the type of, the number of patients that we have, they are not enough. They are remotely not enough. And again, in the same report, I think one of the biggest highlights I had is that despite them just being that small number, they are also concentrated within Nairobi and the Nakuru region. Again, it leaves some of the areas in the country very, very dark. but what is the institute doing about that? Because we are the arm of the government, basically, who have been mandated to ensure that, you know, all these specialists are there. So, for example, the beginning of this year, we were in Turkana and Samburu, where we are continuously in stages of helping them set up cancer centers, because we believe in one of our mandates is actually to offer protection for cancer patients and to have them be treated within their social environment because of the social protection it offers. So in Turkana, we were there, and we're also working on, I told you one of our mandates is training. We are going to be sponsoring a medical officer deployed from there to actually undertake the radiation oncology course at the University of Nairobi. In Samburu, they're actually lucky because their sponsored doctor actually just graduated last year, so he's there and is currently working tirelessly to see patients within Mararal. So we are sorting out those issues piecemeal, one step at a time, but we are getting there.
Which counties are the most affected by cancer?
Oh, O'Brien, we cannot say there's one county that is more affected.
I mean,
than
like
the
where a county with the highest prevalence of cancer patients in Kenya.
So, for example, like this year when we were doing the cervical cancer awareness month, we actually saw that Nakuru County had been reported to be having the highest number of cervical cancer cases.
County.
Yes, but you can understand, Nakuru County, it's centrally placed. We have the Nakuru Cancer Center. It has the radiotherapy, which is a service that is very dire for patients with cervical cancer. So it would make sense because, again, also, where did we get this information from? We have cancer registries or where we report data. So we're relying mostly on what we call the hospital-based cancer registries. Although right now the Institute is working tirelessly. We employed 12 cancer registrars last year and deployed them within the country to actually collect data, so that when, O'Brien, the next time I come here and you ask me which county is more affected by cancer, I can give you real-time data.
So, but at this moment, we don't have such data?
We don't have that. But you'll find like Nakuru, the areas around Nairobi will have higher than normal numbers of cancer patients. Yes.
And so, then how then do you approach your, your management of cancer if you are lacking in terms of data of the counties that are worst affected? Because, I mean, for you to develop a proper cancer management policy, you need to know exactly where are the people, what kind of cancer are they dealing with, so that you can deploy the resources that are needed there.
I think we are tackling this and we are doing it, I think, right and very well. Other than the 12 registrars, of course, that are employed by the National Cancer Institute, we support other county government registrars to, to abstract this data and feed it into the NACARE. NACARE is the system that has all the cancer data surveillance. So we also offer trainings free of charge for people who have a background in health records to come and learn this abstraction and everything. And right now, they're actually in real time feeding the data. Yes.
Phoebe, I want to hear this from you. I mean, when you look at, health services, these are devolved services. They're supposed to be handled by county government. Of the 6 cancer hospitals that we have, none of them is owned by any county government. All of them are level 6?
They are
owned by the county government.
Like, for example,
like Jaramogi in Kisumu, until recently, is when now the government took it up.
But Jaramogi is a level 6?
Yeah, it is a level 6 hospital, but it was managed by Kisumu County. But now recently it has been upgraded to a parastatal. So it is
a parastatal now?
Yes.
So we don't have any other facility that is managed by county government?
Out of the 6, no.
Out of the 6,
Out of the 6, no.
Yeah.
But every county, they have what they call the county referral hospital.
Yes, and that's why we were saying that some of the efforts that the government is doing, they're trying to put up what we call the regional cancer centers. And I think until very recently, there have been a lot of trainings, and most of them were being done through the counties. So the oncology nurses were going out for trainings, the oncologists, hemat-oncologists, they were going out for training. So out of the regional centers at the counties now we will have, because the main work of the regional centers at the counties was to decongest the so-called county, the so-called national government centers.
County referral hospitals.
And now just to answer also on how, we also need to concentrate on research, because if you look at the cancer statistics in the country, for example, if you go towards Garissa, you'll find mostly the esophageal cancers around Garissa, northeastern. Then you ask yourself, why is it a lot of esophageal? Is it that there was some chemicals that were deposited there maybe a long time ago? Why? If you go to central Kenya, for example, they'll have some cancers around the flower growing, the agriculture. So then ask yourself,
around Naivasha.
Around Naivasha, is it pesticides? Is it the kind of pesticides that we're using?
And what kind of cancer would you find in Naivasha, for example?
It is mainly spread out cervical.
Or cervical?
Yeah.
Yes, mainly cervical, and also breast for ladies. We are having also some prostate. If you go to Mombasa and other areas of the coastal, again, the throat cancers are there.
Yeah.
So there's a lot of research that is currently happening, and we are hoping that it will give us the causative, so we can link up, because what they're saying, currently we just have what they're calling the risk factors, but now the exact ones to link it up, then there is gap for adequate research to be done in such areas.
And in terms of developing statistical data, whose role is this?
That is the role of national cancer.
That's our role.
And that's why Dr. Michelle said they have...
Is it happening?
It's happening. It's happening. We actually just finished out awarding the calls for proposals to fund research. And I think the previous financial year we gave out 13. And this financial year we are targeting to...
13 what?
Grants for research related to cancer. And we don't want to stop there. We also want to actually venture into clinical trials. I think one reason the research, other than just finding out what is the cause and everything, so many people come and bring molecules and tell us that this is going to improve their 5-year survival rate. But when you look at where that particular molecule, where the clinical trial took place, it took place in a Caucasian population, white people. Like there were no people of African descent that were involved in that clinical trial. So we understand that our genetics play a very important and big role in cancer carcinogenesis. So we actually are very aware of that, and we are working with different entities, different pharmaceutical countries to actually set up sites for clinical trials, so that also as Kenya, as a molecule is being launched, it has also been tried in us, so that we know how it's going to behave, what are going to be the side effects and all that.
Help us understand things. I mean, you since 2013, you held the first National Cancer Summit. The next one is coming next week in 2025. That is 2 years later. What have you achieved under the first summit?
Actually, the achievements were what I was listing for you under the 5 pillars. I've told you, like, annually now we are comfortably able to screen more people. And like this, the previous financial year, we were able to introduce routine colorectal cancer screening, because that's among also our 5 priority cancers. Again, we go to diagnosis. We cannot downplay the impact or the big strides that Kenya has made in the aspect of nuclear medicine. We started as 2019 with no PET scan at all in the country, to 2025 where we have 7. 2 of those are actually in KUTRH, government funded, fully reimbursed under SHA. Those are strides. So those are some of the achievements. We go again to treatment. We have now Garissa. It's serving the northeastern corridor. We did not have that as a regional cancer center. We want to talk about the bunkers. Mombasa now, we are about to commission the second LINAC, that's the linear accelerator. Same for Nakuru. There are plans to
actually... It's going to be where?
Coast General Hospital, so they will have 2. Again, we decongest. We reduce the radiotherapy waiting times. Nakuru, the same. We reduce. KNH, very soon, we're also going to be doing the same. And there are also plans.
We don't have one at KNH.
We have one, but now we want to actually enhance its capacity, because you see, every time you think about cancer, the first place you're going to think about is, can I get treatment at KNH? So we want here people to be able to still get treatment at KNH. The fact that we are still expanding and growing these other regions, we also need our anchor hospital to be fully functioning. You get?
Yeah.
And then there's also the aspect of the PET scan. We have now the fully government one at KUTRH. Very happy about that. There are plans to have another one installed at MTRH. Again, decongesting and improving. Then we go actually to the aspect of financing. I still feel as government we have done well with SHA. And there's actually, in terms of the benefits, there was a panel, a gazetted review panel to review the benefits package and continuously, appraise the government. And then partnerships, I spoke about Pfizer, Roche, just a few. There are so many that are working behind the scenes, and all these people are working with the government because, you see, they have shown their faith with the government. They believe in SHA, and it is working.
Help us understand things. I mean, from where you see it as the National Cancer Institute of Kenya, when you look at SHA, and the benefit it offers to cancer patients, what improvement do we need to do on SHA to help cancer patients?
We do actually sit in strategic consultative meetings with SHA, and for us as an institute, we are actively and always advocating for the expansion of the benefit in terms of how much it can, pay for services. I think that's our key goal. We support them, but we also advocate for the expansion of the benefits package.
And when you're advising them to expand, you would want them to expand from what to what?
Oh, Brian.
Because you must be having a figure.
As a base, if we could go back to the 600,000 and also go back to...
That is for treatment.
And also go back to the aspect of it being per person. Not per household. Because I have seen cases where a husband and a wife actually do have cancer. Not at different times, at the same time. So it's a reality. So these realities of treatment, we have to find ways of addressing them within the health system that we have.
So you'd prefer a situation whereby we revert to coverage per patient?
Per patient.
Not per house?
Not per household.
Very well. Phoebe, when you interact with the patient and their interaction with SHA, what do they highlight as the major challenge in SHA coverage?
Thank you, O'Brien. Today only, just before I came here, I think KENCO received over 20 feedback.
20?
Within 1 hour, because we just said, hey, we are going out there, we are doing the 1-year analysis, as I told you, because the government also looks up to us to give them feedback from the patients. They are saying, kindly please expand the benefit package. Because cancer is different from malaria. Cancer has a tumor that does not have an advantage of time. The tumor grows exponentially, and it has to be handled by the treatment options that we mentioned earlier. So what they're facing a lot is that the 400,000, I will repeat, is working. But once it is depleted, then there is what we call treatment interruption. Treatment interruption means if I paid for my SHA in July and I deplete my cover in next year, let's say by May, I have to wait for another July, because that is what counts. And I think also information needs to go out there. There's a lot of misinformation about the year or the capitation and all that. So what SHA does is that it counts. If I pay my cover today in June, it will count 12 months. So my financial year will end next year by June. So it is not about September, October. That misinformation needs to be handled.
So if you exhaust your cover, let's for example say that you paid in June, and then you exhaust your cover, let's say in December, the same year, does it mean that you have to wait for another 6 months?
And now that is how the government came with the buffer, the perfect buffer of the emergency chronic and critical illness fund. But the basket is empty. The basket is empty. So we need capitation in that basket. And this is supposed to be funded
by National Treasury?
Yes, National Treasury.
So why is it empty?
So we understand, I think I can know why it is empty, because what SHA envisioned was to have at least 60% of the informal settlements to be part of it. But as at now, they're hardly at 40%. So it means they're not getting the money from the contributors. But now we are coming back to the same government and said, okay, the contributions are not enough. How about now from Treasury? Because that is what the Act says. The Act says it will be funded from Parliament, funded from grants, funded from other sources, from government, from exchequer. So then, if the basket has something, then the patients will be able to access the 150 that is supposed to be there. But now we are saying it should not be on paper. Let it be real. So when they dip in the basket, let them find something. So they're telling us that. And then what they're telling us also so loudly is that, please, the annual one is not working. We go back and tell them pay for 6 months and all that, because asking somebody struggling to put food on the table, and you know, cancer treatment is expensive. It impoverishes. I'm sure you're in a WhatsApp group of contributions for someone. So they cannot access the treatment. They cannot be able to pay out of pocket because of the expensive nature of it. So if it is stretched a bit, even if it is 550, let it be 550 for the main one, and then let them still have funds in the chronic illness fund. And then they're telling us, please count it per individual. Because right now, if you look at the number 3 causes of death, it is cardiovascular diseases, infectious diseases, cancer. Those 2 are chronic illnesses. It means if you're in a household, highly likely you'll have 2 people with chronic illness, and they will still be depending on the same social health insurance fund. Very good. I mean, we're almost depleting our time, but I just want to give you a minute, Dr. for you to give hope to cancer patients in this country that National Cancer Institute is doing to help them.
So, first of all, let me just tell the viewers that they are very welcome to come and attend the Cancer Summit starting on the 27th. Again, on the 27th, we are doing something again spectacular. We are offering free cancer screening services, prostate. This is where? Kongoni Primary School in South Sea, free from 8 a.m. to 4 p.m. Again, we make such realities happen because of the partnerships that we have created within this space. So we have different partners coming to have that. Then from the 28th to 30th, now we have the in-depth discussion where unity of voice matters, you know.
And this is where?
The Edge Convention. The Edge Convention, yes, South Sea. Yes, from 28th to 30th. Come meet the different stakeholders, the big players in the cancer space, understand what they are doing, also give your input. Even as the media, we say the media has a very, very big space, because when you talk about these statistics, actually you give them, you humanize them, and then it makes sense for us, like, why are we doing this? So my message to anybody who's watching there is that under this government, we have decided that cancer treatment is not a privilege. It's actually a right, and we are trying to make this work through the Social Health Authority. So it's also a call for us, like, get out there, register, and pay up. It saves lives. Very good. Thank you.
What about you?
Thank you, National Cancer Institute of Kenya, for bringing everyone on board. And we are saying the government to open up more access. Cancer treatment is expensive. When we have access, it means somebody is able to bring the medication at a highly subsidized, and the more it is subsidized, the better people. Please expand the oncology package so that we do not have to report over 70% of late diagnosis.
Very good.
Thank you.
Ladies, thank you very much indeed for joining us, and of course for sharing that critical insight on cancer prevention, management, and of course treatment in Kenya. Your time is highly appreciated.
Thank you very much.
Very good. I mean, for the last 52 minutes, we've been talking about nothing else but cancer management, treatment, and of course prevention here in Kenya, and what the government is doing in partnership with the private sector, because this battle cannot only be won by government alone. It will take government as well as private sector and individuals to win the war on cancer. You have been watching Inside the Government live from Broadcasting House, and of course we've been talking to Dr. Michelle Ngu. She's the Director of Cancer Prevention and Control Directorate at the National Cancer Institute of Kenya, and of course Phoebe Ongadi, the Executive Director, Kenya Network of Cancer Organizations, joining us here tonight. My name is O'Brien Kimani. Thank you very much indeed for your time. The Prime Edition is coming up next. Stay right here.